You are most welcome to this talk. Now, today we are going to be looking at something that I think is profoundly important for public health, and that is the issue of government data refusal. What do I mean by this? I mean the phenomenon we have observed across multiple countries where governments have either stopped collecting, stopped publishing, or significantly reduced the granularity of health data that was previously available to the public. And I want to walk you through what has happened, why it matters, and what we can still learn from what remains accessible. Now, let me be very clear about what this video is and what it is not. This is an educational discussion about data transparency and public health surveillance. I am not here to provide medical advice. I am not here to tell you what to do about your own health. What I am here to do is help you understand how to read public health data, why access to that data matters, and what questions you might want to ask when data suddenly becomes unavailable. If you have any health concerns, please do consult with a qualified healthcare professional who knows your individual circumstances. Right, so let us begin by looking at what has actually happened across several major health systems. And I think the best way to understand this is to look at specific examples from different countries and see the pattern that emerges. In the United Kingdom, we saw something quite remarkable happen with the Office for National Statistics data. Now, for those who are not familiar, the Office for National Statistics is essentially the statistical authority for the United Kingdom. They collect and publish data on all manner of things, including mortality data, which became extremely important during the pandemic period. What we observed was that certain categories of data that were being published regularly, weekly in some cases, began to be published less frequently. Some categories were discontinued entirely, and in some cases the methodology for calculating certain figures was changed in ways that made historical comparisons more difficult. Now, let me show you what I mean by this. The data on deaths by vaccination status, for example, was being published regularly. This was incredibly valuable data because it allowed researchers and indeed members of the public to understand outcomes stratified by whether someone had received vaccinations, and if so, how many doses. This data stopped being published. Now, the official explanation given was related to data quality concerns and the complexity of the analysis. And to be fair, these are legitimate statistical considerations. However, the question that many people asked was, if there are quality concerns, why not address those concerns and continue publishing rather than stopping publication entirely? Let me walk you through another example. In the United States, the Centers for Disease Control and Prevention, which is the primary public health agency, made several changes to their data reporting. Now, some of these changes were presented as improvements, as modernization of data systems, and in some cases that may well be accurate. Data systems do need to be updated. However, what was observed was that certain granular breakdowns became unavailable. Hospital admission data, for instance, saw changes in how it was reported and what level of detail was accessible to the public. Now, this is the key point I want you to understand. When we are talking about public health surveillance, the granularity of data matters enormously. Let me explain what I mean by granularity. If I tell you that there were 100,000 hospital admissions last month, that is useful information at a very basic level. But if I can tell you that of those 100,000 admissions, this many were in the age group 0 to 17, this many were 18 to 49, this many were 50 to 64, and this many were 65 and above, now you have much more useful information. You can see where the burden is falling. You can see trends within specific populations. You can make more informed decisions both at the policy level and at the individual level. When granularity is reduced, our ability to understand what is actually happening diminishes correspondingly. And this is not a trivial matter. This is fundamental to evidence-based public health. Let me now talk about the sources we are working with and their limitations. For this discussion, I am drawing on publicly available government websites, published statistical bulletins, peer-reviewed papers that have analysed changes in data availability and journalistic investigations that have documented these changes. Now, each of these sources has limitations. Government websites present data in the way governments choose to present it. Statistical bulletins may change methodology without always making those changes prominent. Peer-reviewed papers take time to publish and may be analysing data that is already months or years old, and journalistic investigations, while valuable, may sometimes lack the technical statistical expertise to fully contextualise what they are reporting, so we must approach this topic with appropriate epistemic humility. We are trying to understand a complex picture with incomplete information, which is, ironically, exactly the problem we are discussing. Now, let me walk you through what the pattern of data refusal actually looks like when we examine it systematically. And I want to be very careful here to distinguish between different categories of what might be called data refusal. The first category is outright discontinuation. This is when a particular data series simply stops being published. 1 week or 1 month there is data and then there is not. This is the most obvious form of data refusal, and it is also the most concerning because it represents a complete loss of visibility into whatever that data was measuring. The second category is reduced frequency. Data that was being published weekly begins to be published monthly or quarterly or annually. Now, at first glance, this might seem like a minor administrative change, but in a rapidly evolving public health situation, the difference between weekly and monthly data can be enormous. By the time monthly data is published, the situation may have changed significantly, and opportunities for timely intervention may have been missed. The third category is reduced granularity, which I mentioned earlier. The data continues to be published, but with less detail. Age breakdowns disappear, regional breakdowns disappear, stratification by relevant health factors disappears. The headline number continues, but the ability to understand what is driving that headline number is lost. The fourth category is methodological changes. This is perhaps the most subtle form of data limitation. The data continues to be published. It continues to be published at the same frequency, with the same level of apparent detail, but the way the numbers are calculated has changed. And if those methodological changes are not clearly communicated and explained, it becomes very difficult to compare current figures with historical figures. The time series is effectively broken. Now, I have been presenting this in a somewhat critical light, and I want to be fair to the other side of this discussion. There are legitimate reasons why data publication practices might change. Let me outline some of these. First, privacy concerns. As data becomes more granular, it becomes potentially more identifiable. If you are publishing data on a rare condition in a small geographic area stratified by age and sex, you might be publishing data that could identify specific individuals. This is a genuine ethical concern, and it is appropriate for statistical authorities to take steps to prevent inadvertent disclosure of personal health information. Second, data quality. If there are genuine concerns about the accuracy or reliability of a data series, it may be appropriate to pause publication while those concerns are addressed. Publishing inaccurate data is not helpful. Indeed, it can be actively harmful if it leads to incorrect conclusions and poor decisions. Third, resource constraints. Collecting, processing, validating and publishing data requires resources. Staff time, computing resources, statistical expertise. In a period of strain on public health systems, it may be that difficult choices have to be made about where to allocate limited resources. Fourth, methodological improvements. Sometimes a data series is discontinued not because the information is no longer wanted, but because it is being replaced by a better data series that captures the same information more accurately or more comprehensively. These are all legitimate considerations. The question is whether they adequately explain the pattern of data changes we have observed, or whether something else is going on. Now, here is where I want to introduce an important concept, and that is the concept of asymmetric transparency. What do I mean by this? I mean situations where data that might be seen as supporting a particular policy position continues to be published and promoted, while data that might be seen as raising questions about that policy position becomes less available or is discontinued. If data availability is being driven purely by the legitimate considerations I just outlined, privacy, quality, resources, methodology, then we would expect data changes to affect all categories of data roughly equally. We would not expect to see a pattern where only certain types of data become unavailable. If we do see such a pattern, then it raises questions about whether other factors might be influencing decisions about what to publish and what not to publish. Now, I want to be very careful here. I am not making an accusation. I am identifying a question that I think deserves investigation. The presence of asymmetric transparency would not by itself prove any particular motive, but it would suggest that the explanation is not purely technical or administrative. Let me give you a specific example of how this might manifest. Imagine a situation where data on vaccine adverse events is being published in great detail, with frequent updates and extensive stratification. And imagine that at the same time, data on vaccine effectiveness is also being published in great detail, with frequent updates and extensive stratification. This would be symmetric transparency. Both types of data that support different perspectives on the question of vaccination are equally available. Now imagine a different situation where data on vaccine effectiveness continues to be published in great detail, but data on vaccine adverse events becomes less frequent, less granular, or is discontinued. This would be asymmetric transparency. The data landscape has tilted in a way that makes certain conclusions easier to draw and other conclusions harder to draw. I want to emphasize again that I am using this as a hypothetical example to illustrate a concept. The reality across different countries and different health topics is complex, and I would not want to oversimplify it. But I do think this concept of asymmetric transparency is a useful analytical tool for thinking about patterns of data availability. Now, let us talk about the implications of data refusal for clinical practice and public health research. And I think this is really the core of why this matters so much. Clinical practice at its best is evidence-based. Clinicians make decisions based on the best available evidence about what works and what does not work, about what the risks and benefits of different interventions are. But that evidence comes from data. Without data, there is no evidence base. And without an evidence base, clinical decisions become matters of opinion or authority rather than science. When governments stop publishing data or reduce the quality and granularity of data they publish, they are directly affecting the evidence base that clinicians rely on. This is not a theoretical concern. This has practical implications for patient care. Similarly, public health research depends on access to population-level data. Epidemiologists, biostatisticians, health economists, all of these researchers need data to do their work. When data becomes unavailable, research becomes impossible. Questions that could have been answered remain unanswered. Patterns that could have been detected remain hidden. Interventions that could have been evaluated remain untested. And there is a temporal dimension to this that makes it even more concerning. Some data can only be collected at the time. If you do not record mortality data at the time deaths occur, you cannot go back and reconstruct it later. Historical data that is not collected is lost forever. When a government decides to stop collecting a particular type of data, it is not just making a decision about the present, it is making a decision that will affect our ability to understand that period of history in the future. This brings me to what I think is one of the most important points in this entire discussion. Public health data is a public good. It belongs to the population, not to the government. Governments are custodians of this data on behalf of the public. They collect it using public funds, they process it using public funds, and in a democracy there should be a presumption that it will be made available to the public with appropriate safeguards for individual privacy so that the public can understand what is happening in their own communities. When governments withhold data or reduce data availability without compelling justification, they are in a sense appropriating something that belongs to the public. They are claiming ownership of information that the public has a legitimate interest in. Now, I want to acknowledge that there is genuine debate about where the line should be drawn. Not all government information should necessarily be public. There are legitimate secrets. There are legitimate privacy concerns. There is legitimate need for deliberative space within government. But public health data, the basic facts about patterns of disease and death in a population, seems to me to be clearly on the side of information that should be publicly available. Let me now turn to what we can actually learn from the data that remains available, even in an environment of reduced transparency. First, we can look at all-cause mortality. This is perhaps the most robust measure we have because it is very difficult to manipulate. Either someone has died or they have not. The cause of death may be subject to debate or misclassification, but the fact of death is binary. If we see unusual patterns in all-cause mortality, that tells us something important is happening, even if we cannot fully explain what that something is. Second, we can compare across jurisdictions. Different countries have different data publication practices. When one country reduces transparency, we can look at comparable data from other countries to get a sense of what might be happening. Of course, different countries have different demographics, different healthcare systems, different public health contexts, so comparisons must be made carefully, but they can still be informative. Third, we can look at proxy measures. If direct data becomes unavailable, there may be related data that can serve as a rough indicator. Emergency department attendances might serve as a proxy for acute illness burden. Ambulance call-outs might serve as a proxy for medical emergencies. Life insurance claims might serve as a proxy for mortality. These are imperfect measures, but in an environment of data scarcity, imperfect measures are better than no measures. Fourth, we can pay attention to what is not being said. Sometimes the absence of data or the absence of certain types of analysis is itself informative. If an obviously relevant question is not being addressed in official publications, that may tell us something about whether the answer to that question might be uncomfortable for those responsible for publication. Now, let me talk about what we know and what we do not know, because I think this distinction is crucial for thinking clearly about this topic. What we know is that data publication practices have changed in multiple countries. We know that in some cases data series have been discontinued. We know that in some cases granularity has been reduced. We know that in some cases frequency has been reduced. These are observable facts that can be documented. What we also know is that in many cases the official explanations for these changes have been technical or administrative in nature. Privacy concerns, data quality concerns, resource constraints, methodological improvements. These explanations have been offered, and they may in some cases or in all cases be accurate. What we also know is that these changes have made it harder to answer certain questions about public health. This is a straightforward consequence of reduced data availability, regardless of the reasons for that reduction. What we do not know is the full set of reasons behind these changes. Official explanations may be complete and accurate. They may be partial, they may be pretextual. We simply do not have enough information to make confident judgments about motivation. What we also do not know is what the data would show if it were available. This is, in a sense, the point. The absence of data is an absence of knowledge. We cannot know what we would have learned from data that does not exist. What we also do not know is whether the pattern of data changes represents a coordinated policy across countries or independent decisions by different governments responding to similar pressures. The timing and nature of changes in different countries is suggestive, but we do not have direct evidence of coordination. I want to now briefly discuss what individuals can do in this environment of reduced data transparency. First, support organisations that promote data transparency. There are non-governmental organisations, academic institutions and journalistic outlets that are working to preserve access to public health data and to document changes in data availability. These organisations deserve support. Second, ask questions. When official data becomes unavailable or less available, ask why. Submit freedom of information requests where appropriate. Write to elected representatives. The more people ask questions, the harder it becomes to quietly reduce transparency without explanation. Third, preserve what data exists. If you are a researcher or a data analyst, consider downloading and archiving data that is currently available. Data that is published today may not be available tomorrow. Having independent copies preserved can be valuable. Fourth, develop skills in data analysis. The more people who can read and interpret public health data, the harder it is to present misleading summaries. A data literate public is a public that can hold governments accountable. Fifth, maintain epistemic humility. Just because data is being withheld does not mean that whatever is being hidden is nefarious. There may be legitimate reasons. Our uncertainty about what the data would show should make us cautious about drawing confident conclusions based on the absence of data. Now, I want to address what I think is a risk in discussing this topic, and that is the risk of sliding into conspiratorial thinking. The fact that governments have reduced data transparency is, in my view, a legitimate concern, but it is a different thing to say that we have concerns about data transparency than to say that we know what is being hidden and why. We do not know. We should be honest about that. The appropriate response to reduced transparency is to advocate for increased transparency, to analyse what data remains available as carefully as possible, and to maintain appropriate uncertainty about what we do not know. The appropriate response is not to fill the gap in our knowledge with assumptions and then treat those assumptions as if they were established facts. I have seen this happen, and I think it is counterproductive. When people make confident claims about what hidden data would show, and then those claims turn out to be wrong, it discredits the legitimate concern about transparency. It makes it easier for those who want to dismiss these concerns to say, look, these are just conspiracy theorists making things up. We are more persuasive when we are honest about the limits of our knowledge. We are more persuasive when we distinguish clearly between what we know and what we suspect. We are more persuasive when we acknowledge that there may be legitimate explanations even as we ask for those explanations to be provided. In summary then, here is what I think we can say. Government data refusal is a real phenomenon that has been documented across multiple countries. It takes various forms including discontinuation, reduced frequency, reduced granularity, and methodological changes. There are legitimate reasons why data publication practices might change, but the pattern of changes raises questions that have not been fully answered. Reduced data availability makes it harder to conduct public health research and to maintain evidence-based clinical practice. In the absence of certain data, there are still analytical approaches that can provide partial insight, and individuals can take actions to support data transparency and to develop their own data literacy. What remains uncertain is the full set of motivations behind changes in data publication, what the unavailable data would show if it were available, and whether we will see a return to greater transparency in the future. I think this is fundamentally a question about the relationship between governments and the populations they serve. In a healthy democracy, there should be a presumption of transparency. The burden of justification should be on those who want to withhold information, not on those who want access to information. When that presumption is reversed, when governments feel entitled to withhold data without compelling justification, something has gone wrong with the democratic relationship. My hope is that through continued advocacy, through continued analysis of what data remains available, and through continued public attention to these issues, we can move toward a situation of greater transparency. But that will require sustained effort from researchers, journalists, civil society organisations, and individual citizens who care about having access to the facts about their own health and the health of their communities. This video is for educational and informational purposes only. It is not medical advice. If you have symptoms or concerns, please consult a qualified healthcare professional. We use publicly available data and reputable sources, and interpretations may evolve as new evidence emerges. Thank you for watching.